Welcome to the Oral Surgery Fight Club podcast. This is a collection of mock cases in the field of oral and maxillofacial surgery in a question and answer format conducted on Zoom. Enjoy. Some quick stats. If you guys, I'm not sure how many of you have been through the ABOMS handbook yet, but in 2023, pass rate, first-time candidates, 60%. They keep this overall percentage pretty tight, around 70, except for when in 2021, I think they had an aberrancy, something like that, because 93% pass rate, there's almost no point to having a board when your pass rate is that high, if you're going to pass everybody, unless everybody's spectacular, but I don't know about that. Examination roadmap. Guys, this is all a big game. The boards is mainly, it's a very unique exam in how you're being tested. It's nothing like a multiple choice exam. This is not the type of test where, you know, we're all accustomed to taking, which is you're reading something in a book and you kind of recognize it or think on a multiple choice exam. You're forced to articulate what you know. You're forced to speak it, say it, and it's an exam of, you know, what would you do? We're going to keep saying that throughout this whole, you know, next 3 months. What would you do? What would you do? This is not a literature review. The exam is 3 sections, each with 4 12-minute cases, and they keep to that. They're not going to let you talk over time. You don't get credit if you talk into 13 minutes, and they're going to be cutting you off repeatedly. It's not to be rude. It's just to keep the exam concise and fair to everybody. So each section, I'll go through this a little more quickly, but each section is 48 minutes. They will tell you you're on section 1, and they'll sit you down. You'll have two examiners across from you at a, you know, pretty small desk with a monitor there. And they tell you, look, this is section 1, orthognathics, infection, TMJ, and pathology. They are not going to launch into it and say, this is an infection case. They're not going to make it that obvious. But knowing what section you're on, it is helpful, I guess, if you want to try to memorize what these sections encompass. But every case, again, it's a test of what would you do. So if they start, you know, going in one direction and pushing the questions that way, then it's great. You'll pretty much know, okay, this is an infection case. This is a TMJ case. They're not going to walk you through, what am I trying to say? They're not going to trick you. It's not an exam where they're trying to trip you up. They'll definitely ask you to clarify some things if your answer is sort of in a roundabout way. But anyway, let's go through. Anyway, this is the ABOMS handbook. You guys can find it on their site. There's some deadlines there. The examination roadmap. I'm going to go into this case first. Let me move you. Let's play this. Okay. So this is straight from their presentation at AMIS. You know, all rights reserved to ABOMS. I'm not trying to plagiarize stuff, but they made this very public. Candidates are scored on 3 skill areas. So there's 6 different things they're sort of looking at when you have examiners across from you. Data gathering, complications, management, ethics, professionalism, and then additional topics, which they'll kind of pepper in. There may be a question or 2 sort of peppered into an infection case or something like that on how would you handle the language with your referral. You know, if they made a mistake or referred you, you know, sunk an implant into an ORN patient, something like that. They grade you on those aforementioned skill areas, graded 1 through 4. I heard sometime back, you know, the presentation they give you right before you take the exam, they show you the kind of rubric. There's I think a total of 72 possible points. I don't know why they wouldn't make their rubric public exactly, but this is the most they're exposing right now. Demonstrates understanding, minor gaps, and then 2 being significant gaps, 1 being you don't know what the hell you're talking about. This is an exam of what would you do? It's not a literature review, as I said. It's not an exam of, well, this is what we did in residency. It's what would you do? So as best as you can in these coming weeks, months, it's a learning process. Like we're gonna go through it. I expect some of you guys to answer like something that you wouldn't normally do. When the pressure's on and we start going through these cases, it's really tough to put yourself in that situation. But that's the point of all this. When we're going through these cases, the pressure is supposed to be ratcheted up a little bit. The sessions are recorded. It's kind of going to be out there. So I applaud you guys for subjecting yourself to this sort of trauma, but it's repeated exposure to this sort of trauma that's going to get you through the exam and have you feeling a little bulletproof on exam day.
Yeah, and you'll be way more anxious on exam day than you ever will be here. For example, they give the test 1 time a year. It's a lot of money to take it. It's time out of your schedule. It's travel. It's kind of ego.
A whole bunch of other people are freaking out on the bus saying, did you read this? Did you do that? Or did you read that one article? And you're like, you just got to have the blinders on and know you've been through it before.
Yeah.
It's almost, well, maybe Doug can attest to this more than I can, but in a situation where the pressure's on it, or you're handling a firearm or something like that, all your fine motor and your thinking kind of goes out the window. You have to have rehearsed it multiple times before you actually get into that situation. Might be a little violent for this scenario, but who's up first?
I am. Sloan.
All right. Sloan, where'd you do residency? Where'd you train?
I finished at UIC.
Oh, okay. What was your program strongest in, you think?
Orthognathics, and we were pretty heavy in malignant pathology and reconstruction.
Oh, really? Okay.
It was pretty well rounded, but yeah, it started to get a little heavy in malignant pathology and recon. Not that I'm great at that or anything, but definitely had quite a bit of exposure.
Yeah. Are you in private practice right now?
Yeah, I'm in private practice in Arkansas. I'm from Arkansas originally, so.
Oh, there you go. Well, I don't know how much.
Where in Arkansas?
It's been very helpful.
Sloan, where in Arkansas are you?
Currently in Northeast Arkansas.
Cool.
Jonesboro.
You know a guy named Scotty Boulding?
Yeah.
President?
Yeah, Northwest Arkansas, where I originally was practicing. We just moved to Northeast Arkansas. So, yeah, he's got a large practice in that area, Arkansas Oral Facial.
Yeah, he opened one in St. Pete as well, or Clearwater. I worked there briefly.
Okay.
Hey, Rock, could you time this case for us?
Yeah.
Let us know when we hit the 12 minutes.
So you guys will see how fast these 12 minutes go. At 12 minutes, I'm just going to tell Ryan 12 minutes are up. Whatever you guys want to do. If you guys just want to continue for education purposes, that's fine. But just so you know, in the real life scenario, it would end immediately and the examiners would stop and they'd basically get up and leave the room. So
yeah, they actually stop and leave the room. They're not
and they'll be like, thank you. And then it's literally like,
yeah.
So it's, yeah. All right. Tell me when you want to start, Ryan.
I'm ready whenever you are.
Yeah. Let me see.
And then, one other thing I will say, it is the maximum benefit for you guys. Like today, me and Ryan will be the examiners because it's the first day. So I think Ryan's going to do the first case and then I'm going to do the second two. But for the maximum benefit of you guys, sign up to be both the examiner and the examinee as many times as you can. because that'll give you the most practice. And when you're actually the examiner too, it'll show you how you're trying to fit an entire case into 12 minutes, which actually can be kind of challenging. So it helps you kind of understand the process of the exam too. So
Yes.
kind of only aside.
See if I can remember what we're doing. All right. So you get a 65-year-old male presenting with pain in the lower right. He says it's associated with a tooth. How would you like to proceed?
I'd ask him a little bit more about symptoms, onset, duration. Has he had any swelling? Has he had any previous antibiotic treatment? Any constitutional symptoms? And then I'll review the systems. And then
He says, I understand. It's been going on about 2 weeks. He's had this bad tooth for months, but the pain is unbearable, Doc, for the past 2 weeks.
All right. I would then want to know a little bit more about his medical history. I would then get vitals.
Good. So he has diabetes type 2. On vitals, he's a little bit febrile to 39. He says he doesn't have any surgical or social history. Any questions for him as far as his vitals and medical history?
How well controlled is diabetes? Does that get a blood glucose?
Yeah, his blood glucose is about 180. He doesn't see a doctor for it. He says a doctor told it to him a while in the past that he has a touch of the sugars, but
no medications. He's not taking any med.
Not that he takes.
Okay. So I would then go forward with a comprehensive.
Could you describe your physical exam?
Yeah, I'd start out just generally looking to see if the patient's toxic tolerating secretions, have any facial swelling, any asymmetries. Then look at MIO, palpate the inferior border of the mandible, do an intraoral examination looking for swelling, bilateral vestibules, floor of a mouth swelling.
I understand. So your assistant takes this high quality panoramic image. Can you describe what you see?
Yes. The sinuses look fairly clear. I do see a radiolucency associated with the roots of tooth number 31. I don't see any other bony pathology. Patient has a full complement of dentition.
Assuming this patient is a Malampati 1 and does not have any trismus, normal MIO, what would your plan be at this time for this patient?
I would want to know NPO status.
He's NPO.
Yeah. Okay. No trismus.
No trismus. Opening normally to 55 millimeters.
I would give the patient options on either to extract this tooth under local anesthetic or under IV sedation. And
he says, Doc, whatever you think I'd be more comfortable.
Okay. Yeah, I would go forward with or recommend IV sedation and extraction of tooth number 31.
Cool. So you take out tooth number 31 pretty atraumatically. No pus or purulence exuded, and patient goes home. You did give the patient your number, and 3 days later, he sends you a picture looking like this. Somehow, well, just ignore that he's missing the rest of his teeth now, but this is what he looks like. He says, Doc, I'm in some pain. This feels worse than before. How would you proceed?
I would ask whether he's having some dysphagia, denophagia, dyspnea.
He says, Doc, I don't know what those words mean.
Is he having any difficulty swallowing, any difficulty tolerating secretion?
Yeah. He said, Doc, it's very painful to swallow, and I can't open that far.
Yeah, I would
be getting worse. I think I feel chills.
I would recommend the patient go to the emergency department. I would meet him there. I would call the emergency ED staff, let them know I have a patient coming in. I would recommend some labs.
The ED doc is firing off consults left and right to every service while you're there. He also obtains this scan. Can you describe what you see?
This is a contrast enhanced CT axial view. I see a large fluid or rim enhancing fluid collection within it's like the floor of the mouth, possibly involving submandibular space, and then there's some airway deviation.
What would you do at this time?
I would be concerned about airway. I would want to secure an airway on this patient, and I would want to perform an incision and drainage of the infection, and then operate.
So the anesthesiologist walks up to you and says, "Doc, is there anything special you'd like for this case?"
Yeah, I would inform him of the airway compromise and let him know that he may need a wake fiber optic for the patient. I would have a surgical kit.
I understand. So you're in the operating room. Can you describe your procedure, please?
Yeah, I would. After we secure the airway, I would prep and drape the patient in usual sterile fashion. I would then aspirate to obtain cultures if possible. Depending on the site, I assume it's submandibular. And
I understand. Would you put drains in?
yes, I would place drains in the affected spaces.
What would your post-operative plan be for this patient?
So I would recommend the patient remain intubated overnight, an ICU bed. I would, admit the patient, obviously, and then IV fluids, empiric antibiotics until the cultures came back. Pain management, continue NPO status.
Would you round on this patient?
Yes, yeah, frequent.
What would you be following on your daily rounds or bi-daily rounds?
Vitals, also white blood cell count, and then drain out.
Okay. So that patient ends up going to the ICU. Your next patient, who's already there in the hospital, the ED doc asks you to just have a quick look at this patient. He doesn't think it's you that would be involved, but wants you to have a look anyway. This child had a tooth filled a couple days ago. Can you describe what you see?
Yes, I see asymmetry of the left midface and periorbital region extending down to the inferior border. There's overlying erythema.
Now, on your physical exam, you notice this child has erythema of the globe and cannot open the eye very far. What does that indicate to you? What concerns do you have?
Preseptal cellulitis, I would be concerned whether I would want to do an ocular exam, look for any visual acuity, changes in visual acuity, any extraocular muscle or extraocular movement.
On this image they obtained, what are the arrows pointing to?
It looks like the internal carotid and the cavernous sinus.
How would you differentiate cavernous sinus thrombosis from orbital apex syndrome?
Orbital apex, you will have changes in visual acuity. You would have optic nerve involvement.
I think that's pretty good. That's all I got, Rock. I don't know how far we are for the...
Sorry, I had to unmute myself. 3.5 minutes to spare.
I gotta sharpen my swords for the oral boards. I learned them from Patel, and he's the Lord. And I'm his protege. You know I'm gonna slay all these motherfucking questions today. Cause I got the sound bites. They're gonna make these old men go, ooh, ah, like some afternoon delight. Yo, I got these questions in my sight, and I got the answers. Yo, my answers is so ill, they give you canker sores.
Thanks for tuning in to the Oral Surgery Fight Club. For uncut episodes and sound bites, go to osfightclub.com. You can also download the Oral Surgery Fight Club app in the App Store and Google Play.